So moving swiftly on, another spectacular speaker for you guys, and it's a real privilege to have Dr. Robert Hendry with us, the Medical Director of Medical Protection Society, otherwise commonly known as MPS. He's a GP in background and so is fully aware of the difficulties doctors face in their working lives. He has the credentials for this role. He's completed a Master's of Philosophy in Law, and he's a great speaker to have on board. So can I introduce Rob? Can we make Rob a presenter, please?
Listen, thanks very much. Thanks, Amin and Pooja, for the invitation. I suppose good morning, good afternoon, good evening to everyone. It's fantastic to be joining so many people around the world in the conference. I was really interested to see that there's people from all parts of the globe. Can I too just extend a big welcome to the UK and to NHS practice, to those of you who are already working in the NHS and those of you who are planning to do so in the near future. As the guys were saying, my name is Dr. Rob Hendry. I'm the medical director here at MPS. And what I was really wanting to do today was to talk to you briefly about complaints in general and how doctors are held to account in the UK, because that's probably subtly different or from the regimes in which some of you may be working. I was really interested in a lot of what the previous two speakers were saying, particularly Subodh, about the way people communicate and some of the expectations that may be different when you come to work in the NHS. Because I think getting things right and avoiding problems as far as possible, and also knowing what to do when things don't work out as well as you would hope for you or your patients, can have a major impact on your experience of practice here, especially with all of the other challenges one might be facing at the start of a career in a new country. We'd like to do as much as we can to avoid that, because it seems to be part of human nature that we dwell on the small number of negative experiences we have. We ruminate on them and beat ourselves up about those sometimes, rather than, I think, taking a pleasure and joy from the many positive experiences where patients or their families thank us for what they do. So that's my plan for the next 20 minutes or so. But just before we do that, if I can say a little bit about MPS, the company that I work for. We're a mutual organisation that was set up by doctors to look after doctors over 125 years ago. We're a not-for-profit organisation, which means that all the money we raise, we use to support members and for the benefit of members. And we're not just there as an insurance company to cover claims or legal expenses. We very much see that our role in supporting the profession, and doctors and dentists in particular, is to be able to offer advice and support and a chance to talk things over in confidence with a fellow doctor, because we employ around 50 medics to work for us, as well as dentists and others. And we believe strongly that it's better to avoid problems in the first place. We put a lot of effort into risk prevention. And essentially, that's what I would like to talk a little bit about today. We've got experience around the world. We're an international organisation, and it's been my pleasure to work in all of these areas. Sadly, that's been curtailed recently by COVID, but that gives us an opportunity to understand some of the cultural issues and the different ways that patients and their families respond when things go wrong in different cultures. And we'd really like to help support you when you come to the country. So, how are doctors held to account in the UK? And I'm not going to go into any of these in any great detail, but really just to flag up the fact that there are a number of quite rigid, if you like, ways in which doctors can be held to account if their practice is called into question. The commonest one, obviously, is if a patient or their family complain, and we'll speak a bit more about that this morning. Patients can also sue for negligence. They can ask lawyers to take action against you or the hospital to compensate them. Disciplinary action can also be taken by the NHS employers, and there's a framework for doing that. You've heard mention of the General Medical Council. You obviously need to become registered with the GMC to be a doctor in the UK. And if someone complains to them, they have a disciplinary process that they can follow. If a patient dies in England and Wales, coroners can investigate those. In Scotland, we have a separate system. And very rarely, but you may have heard of some very high-profile cases where doctors, both at consultant and at junior level, have been prosecuted in the UK where patients have died on allegations of gross negligence. These are very, very rare, and I wouldn't want to scare people about them, but you need to be aware of them. And of course, increasingly, the press and other forms of media take an interest in doctors. Some bits of the media love nothing better than a juicy medical story. And I think really the point of showing you this and letting you know that is the NHS does have an indemnity scheme to look after doctors working in the NHS, but it only covers the negligence claims, the civil claims for damages. And that should you run into difficulties in any of these other arenas, that's where we or the other medical defence organisations come in. So I would strongly urge you to consider having adequate protection and support, because these are unpleasant and stressful things and best avoided. So what is it patients actually want in the UK? Well, interestingly, this was a results of a survey, large patient survey that was done a few years ago in Scotland, which is where I live. And you might be surprised to see that the top one there was that patients wanted their doctors to be clean. Now, this came on the back of a number of high-profile concerns about hospital-acquired infections and so forth. And of course, recently with the COVID pandemic, a lot of patients have been anxious about coming to healthcare facilities and acquiring infections. So actually, that's the first there. But I think it does give some insight to the fact that patients expect their doctors to look professional. This is picking up on what the previous two speakers were talking about. They want their doctors to appear as if they're clean, they've been washing their hands, they're following a proper infection control procedures and so forth. And why that's important, we'll talk about a little bit later. They also expect people to be competent. So if you don't know how to do something, there's no shame or difficulty in asking someone for advice or support. Communication is another issue that keeps coming back in patient surveys. And what do we really mean by that? Because it's a rather general catch-all term, isn't it? But there is no doubt patients want their doctors to engage with them, to make them feel that they're being involved in the process, that the doctor is listening to what they're saying and involving them in the treatment decisions. Which leads neatly to the next idea of consent. Again, a lot of talk about that, and I'm sure most of you will have had material on that at medical school and so forth. But in essence, most patients, and there are exceptions, but most patients want to feel that they've been involved in deciding what treatment they have and what their options are. And I know in some cultures it's more usual for patients simply to expect the doctor to tell them what the correct treatment is. And if a doctor starts asking a patient, what do you think is wrong or what would you like to do, they might be pretty unimpressed with the doctor's professional knowledge. But for large parts of the UK population, there is that expectation. And certainly the legal framework that supports that expects patients' consent to be sought. Confidentiality is also very important, and particularly in this time of more social media, exchanging images and stories with colleagues has given rise to a number of concerns where patient information is inappropriately shared, and that can be difficult. And finally, conduct. The GMC will take an interest in how people behave, not just in a clinical setting, but in their broader lives. So use of recreational drugs and so forth can become issues that people worry about. So as I say, this survey, a very large survey, came up with these highlights, if you like, all summarized by these 6 C's. Now, things go wrong in medicine. It's simply a fact of life, and there's been a lot of research to look at this. And we know that from a number of international studies, about 10% of all hospital admissions involve some sort of adverse outcome. About 40 to 50% of those are probably preventable. And actually of those, perhaps as much as 1% could actually involve negligence that would give rise to falling below a reasonable standard. But we know that of these episodes, only a very small proportion, only perhaps 1 to 3% of patients who suffered negligence ever take any action or ever make any complaint. So why is it some people complain and the vast majority don't? And I think this is something to think about from a risk prevention point of view, that most complaints we see come from disappointment, and most disappointment is, if not all disappointment, being related to unmet expectations. So I think, and this really does, I think, build on what the previous speaker was saying, was that when patients come to see you, it's really important to identify and address their expectations as a way of managing the risk of a complaint. So rather than just thinking, what's wrong with the patient, what do I need to do, it's having a thought about why has the patient come to see me and what is it they actually want. Because we know that poor communication, both before and after something is going wrong, is what tends to lead to patients making complaints or taking action. And again, from the research that we've carried out and has been published in the literature around the world, there seems to be something specific about this relatively small group of your patients who will put in complaints or take action. And the features of the patients who do this tend to fall into some broad areas. Firstly, communication, and as I said, we're always talking about communication, but what does that really mean? And a lot of it is about the patient's perception, and often it can be perception rather than reality, but a perception that they haven't been listened to by the doctor, that there's a lack of empathy, that the doctor didn't seem to care, and a lack of information. They said, I didn't really understand what was going on, and then something went wrong, I wasn't happy. But it goes beyond just the exchange of information and communication. And these are more sort of emotional ways patients feel. If they feel disempowered, so if they feel devalued, if they feel that the doctor is being arrogant or isn't interested in them and isn't taking them seriously or understanding that they feel bad about something, that seems to drive a desire to make a complaint. And the other thing, and I think it picks up on a lot of things I've seen, because we as doctors, when something goes wrong, we're upset. We don't like confronting it. But patients often sense that if the doctor stays away from them, doesn't talk to them, if it's a patient in the ward, that you stop visiting on your ward rounds or avoid them, they have a strong feeling of desertion. If they feel abandoned, they're frightened, they don't know what's going to happen. If you don't involve the family, if you say, I can't speak to you, we're not interested, they sense that feeling of abandonment. And certainly they often report staff are arrogant, they wouldn't speak to us. And that seems to be a driver for complaints. So I think worth bearing in mind when dealing with these things, because there's no doubt that poor communication and poor patient satisfaction has been very much proven in the literature to lead to increased complaints. And again, some interesting studies there that the type of doctors who get less complaints, because complaints aren't evenly spread, some doctors seem to get more than others, and the features of the doctors who get less complaints, and this may be worthwhile bearing in mind for those of you who are doing your various exams, is that doctors who appear to explain clearly what they're doing, why they're doing it, and what's going on, give lots of information to patients, and appear caring and kind, have less complaints. Knowing the medical history, patients is really important. Having a look at the records before you see the patient, and being able to reference perhaps some previous stuff to show that you've made an effort to acquaint yourself with them and what's going on seems to make a difference. And spending time with the patients. I know it's difficult when you're busy, there's lots going on, But often patients, when they complain, will say, the doctor just didn't spend enough time with me. And the other thing that's worth bearing in mind is that there are what we would think of as predisposing factors, which are things that are in place and in the patient's mind even before something goes wrong, as well as the precipitating ones. So if patients think that you're rude, if there's been lots of delay, if they've been held waiting, if they think that you're inattentive or apathetic, they will often form a view of you and the unit you're working in before anything goes wrong. And they will often decide in advance, if something does go wrong, I'm going to complain. Whereas if they're in a better place, they're much more likely to tolerate adverse injuries where there's perhaps something goes wrong, they get the wrong treatment, the wrong drug, or have some sort of iatrogenic injury. So what can you do to reduce the likelihoods of complaints when you're working here? Well, certainly professional behaviour, and I'm not going on about it because Parveen and Zubair have both talked, I think, extremely well about the sense of professionalism that makes such a difference to doctors' ability to avoid problems. And self-awareness, being aware where things are being difficult. If you're working in a unit where people are awkward or difficult, reaching out for those mentors or advice or support in the way that previous speakers have spoken about, I think are really important. Being aware of the clinical systems you're working with, whether that's how prescribing is done, how data is managed from confidentiality point of view, where you're getting data within the hospital system, how do you pick up the results, how do you make interdepartmental referrals and so forth. You're going to be really dependent on all these clinical systems, so making sure you understand how they work in advance, and if you don't know, asking and finding out, I think is terribly important because they will save you from problems arising. And certainly as well, I think in our survey of the patients, they said they wanted their doctors to be competent. So making sure that your clinical skills are up to speed, that you're doing, if you're doing procedures, that you've done an adequate volume of them to be competent. And again, if you don't feel you're able to do it, there's no shame in saying, look, I'm not sure how to do this. You know, can I do a bit of shadowing for a while or whatever, before you're simply launched on doing things on your own. Keeping up to date with the literature, keeping up to date with things is important. And we can't stress enough this importance of managing patients' expectations, because I think increasingly patients expect everything in medicine will go well. And one area I think this is particularly important is in obstetrics, because most times things go well. But as we all know, any of us have done any time in obstetrics, at times pretty tragic things can happen. It can get pretty hairy. I don't know, a shoulder dystocia or a footling breech in a prem delivery. And patients who think it's all going to be goodness and light and everything's going to be happy can often get quite distressed and will often put in complaints if their expectations aren't met. So what do you do and what should we think about when things have gone wrong and perhaps a complaint comes along? Well, it's really important that you recognize and report something going wrong early, and that obviously the first thing to do is try to rectify it or prevent further harm. The worst thing you can do is try to cover things up, and as politicians, I think in many countries have found it's often not what you do wrong that's the problem, it's the cover up that is your downfall. So certainly being open and recognizing problems. But make a detailed note of what's happened, because when things are fresh in your mind, get it down on paper, try to understand why you did what you did, because as things go on, you'll be speaking to other people and your memory of events can get clouded. It's important to speak to the patient and their families, to be open and honest, speak to your colleagues, speak to your support group, speak to your mentor. And we at MPS are always there 24 hours a day on our advice line to, if you pick up, if you're not sure what to do, pick up the phone and speak to us. It's all in confidence and it won't be held against you. There is no harm in saying sorry in the British culture in the NHS. And in fact, often patients will say, all I wanted was the doctor to say sorry. It's not an admission of weakness, it's not an admission of guilt, but it is worthwhile bearing in mind. And listen to what the patient says. Don't make them feel, let them feel that they're abandoned, and learn from the events. Patients, and this is the advice and guidance in the GMC's good medical practice that patients, when they complain, they've got a right to receive an open, prompt, constructive and honest response, and where appropriate, an apology. How are you going to be feeling? Having a complaint is horrible. You'll be feeling stressed, you'll be feeling upset. That's normal, and that's why you must take advice, speak to colleagues. Don't bottle it up or keep it to yourself. I'm not going to go into great detail in the interest of time about how you manage complaints hugely, but it is important that where patients write in or complain to you, that that's acknowledged. If you are preparing a response, make sure you see the records, make sure you actually know what's going on, because sometimes these complaints can come in weeks and months later, and that's why it's so important to have had a detailed record made at the time. Reflect on it, discuss it with colleagues before you write a response, and take our advice. We will help you, advise you on how best to respond, whether it's in writing or by way of having a meeting with the patient, and so forth. Who's best to respond? Depending on what your position within the hospital is, it might be yourself, or it might be your consultant, or it might be some of the hospital management, clinical director, whatever. But again, we can talk this through and look at it. Don't always be in denial and think, have we identified something here that I need to think about from my own continuing professional development? So in conclusion, I think what we've been saying is if patients like you, they're unlikely to sue you. So I think that's why it is worth making an effort to relate to the patient. It's also why it's important to relate and get on well with colleagues, because I think as Parveen was saying, happy units provide good care, and the patient will often sense that when they're having treatment. If it's an unhappy unit where everyone's bickering and something goes wrong, they're much more likely to complain. Error is part of practice, so don't beat yourself up if you make a mistake. We all do. It's important how you deal with it. As we said, complaints aren't evenly distributed. We're not all at the same risk, and that you can modify your risks by thinking about your behaviours. Make sure the systems that support you are working as far as possible. And if you don't know, for example, where you're going to get patients' biochemistry from, or how you get their X-ray results, make sure you find out. We keep coming back to this idea of focusing on the patient's expectations and trying to work out what it is they're expecting from the experience. And it's vitally important that you look after yourself and your well-being, again, as we've heard this morning. That's all I've got to say. Obviously very happy to take any questions if people have them. If you want to download that QR code, that'll take you to our website, where we do have some stuff specifically for IMGs, but we're always happy to hear from our colleagues new to practice in the UK. We have a lot of doctors who work with us who've often trained in other parts of the world, so they're always happy to chat, and we're keen to do what we can to make your experience as positive a one as possible. Thank you.
Thank you, Rob, for a very useful talk. Lots of people saying that they weren't aware of how to approach these situations and the difficulties that you highlighted. Some really simple things, such as just being polite, explaining, and not being afraid to apologise makes a huge difference.
Your voice is cracking a little bit, Bridget, so we couldn't quite hear what you were saying. But in the meantime, I'm just going to come out and take on a question, if that's okay, Rob. Someone's mentioned, I've been following the issue of Dr. Adesa Babagaba. What mechanisms are in place to avoid being in a situation like that as an IMG, and how am I protected as an IMG?
Yes, I know Adesa very well, and the really good news is that yesterday she was found by the GMC's panel not to be impaired, and they've taken away all her conditions, so she has survived, and she is a remarkable lady who's shown incredible fortitude through a ghastly time, and it's really brilliant that she's now back working and in paediatrics. So really one of the most impressive individuals I've met in my time doing this work. And off the back of Adesa's really difficult time, I think a lot of parts of the regulatory frameworks that we were talking about, not least the GMC, but the NHS and others, have had to have a very long and hard look at how doctors who've trained overseas, and actually Adesa trained in the UK. She was looking, but obviously there are all these sort of intersectional issues that we referenced. I think the problems are still there to some extent, as we've heard. I think the good news is that people are more prepared now to speak up. I think people are prepared to challenge, and we certainly put a lot of effort into that. There's a lot of organisations, again, we've heard about BAPI and others, and I think there's a confidence growing amongst the IMG community. So I think Adesa and some other doctors who've had high-profile cases have done a heck of a lot to champion the cause, and I hope drive change which was needed.
Yeah. And if for anybody who's been following that case, it's been something that's been going on for quite a while. I know a lot of doctors have had a lot of doubts and worries and fears generate from this case. So it's good to see that developments happened recently, and lots to learn, I think, from
Absolutely
what's happened. But
absolutely, and I think what will be interesting, and I mean, there's been some other cases recently reported. I think what will be interesting is to see how the various organisations, which I think for a long time may have been in denial, are going to address this. So it's, in that sense, I think it's a better place to be because people can talk about it. And I would certainly encourage people. And I think it picks up on what we're talking about, the microaggressions. It's very difficult to deal with that day and daily, but I think if people feel that, they shouldn't be embarrassed about speaking out and seeking help and seeking support, because there are things that can be done, and there are mechanisms to protect people's rights against discrimination. So don't be embarrassed about seeking that out.
Go on, Bridget.
Sorry, just another question, Rob. Not surprised this has come up, really. Someone asking, my hospital offers me indemnity. Do I still need to get separate indemnity?
Thanks, Bridget. Yes, I think I would absolutely urge people to do that. As I mentioned briefly, the hospital's indemnity is only for claims for negligence, so it wouldn't cover referrals to the GMC. It wouldn't cover disciplinary action being taken by the trust against you, or coroner's inquests and so forth. So absolutely, because it can be horrendously expensive, and an average GMC case might cost somebody £50,000 out of their pockets if they didn't have adequate cover.
Yeah, really, really important point actually, and it's one that we do get asked quite a lot. Well, if we've already got cover, why do we need extra cover? And people being aware of these things is really, really important. And just a final question that's come in, I think, more of a general thing. Obviously, we know complaints are increasing, and it's a part of working in the healthcare profession now. But have you seen over time that people have got more accepting of the fact that they are going to get a complaint? Has that changed, do you think, over the last 5-10 years? Perceptions of doctors and the way they plan for complaints almost?
Yes, I think you're right. And I think it reflects the changing sort of balance of power almost between doctors and patients in the UK, which again, I think often comes as a surprise to people coming in from other countries, perhaps, where doctors have had a more elevated position, if you like. So the complaints culture in everything, whether it's, if you go out to a restaurant or you put your car in for a service, people are much more likely to complain. It's become a sort of integral part of the way we simply live our lives in the UK. So I think, yes, there is. And I know, and certainly the work I've done, often older doctors find it even more distressing to get these because they've never really thought about it. Whereas I think for younger doctors coming in, it seems to be more an integral part of society. Whether that's a good thing or not, I don't know, but it's maybe just the way things are.
Yeah, absolutely. But the whole landscape, as you say, is changing, and people's attitudes to it are changing as well, I suppose, and needed to change. Otherwise, the stress.
And of course, people are much better informed with the internet. sometimes a bit misinformed by Dr. Google, but people use language and medical language that certainly when I first started, been very unusual. If a patient used medical language, you knew they were a doctor, whereas now it probably just means they've been on the internet.
Yeah, absolutely. Should we do one more, just in the interest of time?
Yeah, so somebody's asked, do we still need indemnity for an observership or a clinical attachment? I don't know if you're familiar with that, Rob.
Yes, so these were, I mean, I think the answer is yes, I think it's a good idea. And certainly for people who are in these positions, if I don't know if they're being, would these be non-paid observerships? Or would people be employed in the trust?
Non-paid. Most probably be non-paid, I think.
Yeah.
Some are, sorry, some are paid, yeah.
Yeah, I mean, again, we'd be happy to chat it through. We have medical students as members. We don't charge them anything because they obviously don't have any income. Lots of outgoings, but so yeah, we're keen to engage with all members of the profession as early as possible.
Sorry, I think just to clarify, I probably misunderstood that. So I took it as, do you have to pay for the observership? You don't actually get paid to do an observership. So just to clarify that, sorry.
Yeah, so they're not paid, they're just are non-paid observers, but sometimes they have to pay to actually get that observership post.
Gosh, yes, yeah. Well, again, I think we would, I would regard that almost like a medical student sort of level. But I think if you're having any contact with patients, it's worthwhile having indemnity, just because people can sometimes make complaints or allegations completely unfounded, but it's better just to have that support where you need it.
Yeah. Brilliant. Pooja, any last comments?
No, not at all. So thank you, Rob, for taking time out today and providing us with those useful insights. As Rob has highlighted, if you need any more information, we've posted a link in the chat. He also put up a QR code with more information about how MPS can help people who are IMG doctors. So please check out the information provided. There's lots of useful information and they talk about indemnity as a whole. So please check out that link that we've posted in the chat. But thank you ever so much, Rob. Appreciate it as always.
Pleasure.
Thank you, Rob.
Enjoy the rest of the conference. Really good.
Thank you.
Thank you.
Take care. Bye.
Bye.